welcome to the deep dive. Today we're jumping right into atrial flutter. Think of it like a super organized but way too fast electrical loop in the heart's upper chambers, the atria.
Exactly. It makes them contract really rapidly, but regularly.
And that gives you that classic sawtooth look on an ECG.
That's the one. But importantly, the AV node, the gatekeeper between the top and bottom chambers, usually slows things down a bit.
So the ventricles don't go quite that fast.
Usually not, though the rate can still be pretty quick and regular.
Okay, so our mission today is simple. Give you the high-yield essentials on atrial flutter, what you really need to know, cutting through the noise. Ready?
Let's do it. So first up, where does this often come from? A lot of the time, atrial flutter has roots in some other heart issue.
Like what specifically?
Well, underlying heart disease is a big category. Think coronary artery disease or any kind of structural heart disease that's a really significant risk factor.
Structural changes, okay.
Yeah, and things that make the atria stretch or get bigger, like septal defects, holes between chambers, or pulmonary emboli, clots in the lungs.
Valve problems, too.
Definitely. Mitral or tricuspid valve issues, chronic heart failure, cardiomyopathy, which is disease of the heart muscle itself, even rare things like atrial myxoma, a tumor, or pericarditis, inflammation around the heart.
Wow, quite a list.
It is. And even problems with the heart's own electrical system, like sick sinus syndrome or extra pathways like in Wolff-Parkinson-White, can predispose someone.
So the heart's basic setup often has some kind of vulnerability already.
That's a good way to put it.
But it's not just about the heart itself, is it? What other things increase the risk?
No, definitely not. You zoom out, age is a huge factor. Just getting older makes you more susceptible.
The most important one, you could say.
Arguably, yes.
Yeah.
And interestingly, cardiac surgery or ablation procedures designed to fix heart problems can sometimes trigger flutter.
Huh. Ironic.
A little, yeah. Then you've got the more common things: high blood pressure, obesity, drinking too much alcohol.
Right.
Chronic lung disease like COPD, thyroid problems, thyrotoxicosis, specifically even rarer things like pheochromocytoma, electrolyte imbalances, sleep apnea.
Sleep apnea, really.
Yep. And one that might surprise you, starting non-aspirin NSAIDs, like common pain relievers.
Go on.
There's data suggesting a 40 to 70% increased relative risk of developing flutter or fibrillation when starting those.
Wow. Okay, that NSAID link is definitely one to file away. So quick recap on key risk factors for recall. Advancing age,
Top of the list.
hypertension, structural heart disease, CAD, valve issues, chronic lung disease, thyroid dysfunction, and alcohol abuse.
You got it. Those are the big ones to keep in mind.
Okay, now let's get into the nitty-gritty. What's actually happening electrically in the heart?
Right, the pathophysiology. It boils down to what we call a re-entrant circuit in the atria.
Like an electrical signal caught in a loop.
Exactly. It just keeps going round and round a specific pathway in those upper chambers. That's what causes this super fast, regular atrial contractions.
And it's a sawtooth ECG pattern we mentioned.
That's the visual signature. The atria are often firing around 300 beats per minute, sometimes more. But again, the ventricles usually don't keep up pace for pace because the AV node filters those signals. So the ventricular rate might be fixed, often half the atrial rate, like 150, or it might vary.
Depends on how that AV node is behaving.
Precisely.
You mentioned typical versus atypical flutter earlier. Is that about where this loop is located?
Spot on. In typical atrial flutter, which is the most common type, the circuit uses a specific pathway in the right atrium near the tricuspid valve. It's called the cavotricuspid isthmus.
Okay.
And that usually gives you the classic sawtooth pattern, atrial rate 240, 350 BPM.
And atypical?
Atypical means the re-entrant circuit is somewhere else, could be in the right atrium, could be in the left atrium, just not involving that cavotricuspid isthmus.
And the ECG looks different.
Yeah, the ECG patterns can be more variable, and sometimes the atrial rates are even faster, so location really matters for the specifics.
Location, location, location.
Got it.
No. Now, if a clinician sees this rapid, regular rhythm, what else should be on their mind? The differential diagnosis.
Good question. Always important to rule out other possibilities. The main one is atrial fibrillation, AF.
How's that different again?
In AF, the atrial activity is also fast, but it's chaotic, irregular, not that organized loop of flutter.
Okay. AF is chaotic, flutter is organized but fast.
Right. Then you think about Wolff-Parkinson-White again with its accessory pathways causing fast rates. And other tachycardia, sinus tachycardia, which is just the normal pacemaker going fast due to stress or exercise.
Or fever.
Or fever, exactly. And ventricular tachycardia, which starts in the lower chambers and is generally more serious. So, need to differentiate.
Makes sense. Flutter has his fingerprint, but you check for lookalikes. How common is atrial flutter out there?
Well, it's the second most common arrhythmia after AF, so definitely encountered.
But less common than AF.
Yes, significantly less common. We know it increases quite a bit with age, and it's more common in men. About 80% of cases are in men.
Interesting split. What about stroke risk compared to AF?
That's a key point. The risk of systemic embolism, like stroke, is lower in atrial flutter than in AF. Maybe about 30% as frequent, roughly.
Still risk, though.
Oh, absolutely. Still a risk that needs managing, just not quite as high as with AF, typically.
Okay. So how does someone feel if they have this? What are the symptoms?
Clinically, palpitations are very common. That feeling of a fast, usually regular heartbeat
Annoying, I bet.
can be very disruptive. Also, fatigue, shortness of breath dyspnea, sometimes chest discomfort or pain, though maybe less common.
Anything more serious?
Yeah, in some cases, people might faint syncope or even collapse.
And what might a doctor pick up on examination?
You'd find a rapid pulse, obviously. It might feel regular or maybe a bit irregular, depending on that AV conduction we talked about.
That 2.1 block, for example.
Exactly. A 2.1 conduction is really common, giving a ventricular rate around 150. Much rarer, but dangerous, is 1.1 conduction.
Where every atrial beat gets through.
Yes, leading to extremely fast ventricular rates and potential hemodynamic collapse, basically. The heart can't pump effectively.
Scary.
It is. And you might also find signs of whatever the underlying cause is: thyroid issues, alcohol effects, valve problems, signs of heart failure, low blood pressure, breathing difficulties in severe cases.
Right. Linking back to those causes we discussed. So how do you confirm it's flutter and investigate those causes? What tests are ordered?
Okay, investigations. Blood tests are standard full blood count, kidney and liver function, electrolytes, definitely thyroid function tests, maybe inflammatory markers like ESR.
J-slang stuff.
Pretty much. A chest x-ray can check for lung issues or other structural things like a widened mediastinum.
But the key is the ECG.
Absolutely. The ECG is king here. You're looking for those sawtooth flutter waves.
Best seen where?
Often best in leads 2-3 and AVF, the inferior leads. You'll see the fast atrial rate, 240, 340 usually, and that variable AV block, often 2.1 or 3.1.
What if it comes and goes? Paroxysmal flutter?
Good point. If it's paroxysmal, a single resting ECG might be totally normal between episodes.
So then you need longer monitoring.
Exactly. That's where ambulatory monitoring comes in, like a Holter monitor worn for 24 hours or more, or an event recorder the patient triggers during symptoms.
To catch it in the act.
Precisely. And an echocardiogram, the heart ultrasound, is crucial too.
What does that show?
It assesses heart structure, function, looks for valve problems, signs of coronary artery disease, fluid around the heart. Really important for finding underlying causes.
And you mentioned a T sometimes.
Yes, a transesophageal echo. That's used if you're thinking about immediate cardioversion, shocking the heart back to rhythm. It gives a very clear view, especially of the left atrial appendage, to check for blood clots before the shock.
Don't want to send a clot flying.
Absolutely not. Safety first.
Okay, so ECG is diagnostic, echo check structure, bloods, and CXR for context and causes. Let's talk treatment. What are the goals?
The management goals are basically threefold, maybe fourfold. 1, control the ventricular rate, keep the bottom chambers from going too fast.
Right.
2, control the rhythm, ideally get back to and stay in normal sinus rhythm.
Makes sense.
3, and this is critical, prevent thromboembolism, reduce that stroke risk.
Very important.
And 4, address any underlying causes you find. Treat the thyroid, manage the heart failure, etc.
Okay, clear goals. How do you achieve rate and rhythm control?
For getting the rhythm back quickly, electrical cardioversion, the shock is very effective and generally safe.
But you need anticoagulation first if it's been going on for a while.
Yes, if it's been present for more than 48 hours or you're unsure, anticoagulation is needed first to reduce clot risk.
What about medications for rhythm?
Medications can also be used for rate control or sometimes rhythm control. Things like beta blockers, calcium channel blockers, digoxin can slow the ventricular rate. Amiodarone is an antiarrhythmic, sometimes used for rhythm. Availability might vary slightly depending on location.
And for long-term rhythm management?
For long-term, particularly if flutter keeps coming back, radiofrequency catheter ablation is often the preferred option.
Tell me more about ablation.
It's a procedure where they use catheters to find that re-entrant circuit, usually the cavatrocuspid isthmus in typical flutter, and use energy to create a small scar line to break the circuit.
And it works well.
Very well. Success rates are high, like 90–95%. It often leads to better quality of life, less chance of developing AF later, and fewer hospital visits compared to just using drugs long term.
Sounds like a good option for many.
It often is, yeah.
Now, back to that crucial stroke prevention. How is that managed?
It's very similar to AF management. We use a risk score called CHA₂DS₂-VASc.
That calculates stroke risk based on factors like age, hypertension, diabetes.
Exactly. Based on that score, anticoagulation blood thinners is usually recommended for most patients to lower the stroke risk.
But you also have to consider bleeding risk with anticoagulants.
Absolutely. We use another score, often the ORDIT score nowadays, which is preferred over the older Haspy-Leddy score by some guidelines, to assess the patient's individual bleeding risk.
So you weigh the stroke risk against the bleeding risk.
Precisely. It's a shared decision-making process based on those scores and the patient's overall situation. And again, if cardioversion is planned for flutter lasting over 48 hours, anticoagulation is key beforehand.
Got it. Do pacemakers ever fit into the picture?
Not usually as a primary treatment for the flutter itself. They might be needed if, say, the medications used to control the flutter cause the heart rate to go too slow, bradycardia.
Oh, okay.
Or in very specific situations, sometimes a temporary pacing technique called overdrive atrial pacing can be used in the hospital to try and terminate a flutter episode. But it's not a standard long-term fix.
Okay, so mostly rad rhythm control meds, ablation, and anticoagulation. What's the general outlook for someone with atrial flutter? The prognosis.
With proper management, the prognosis is generally quite favorable. People can live well with it.
But it can come back.
Yes, recurrence is definitely possible even after ablation sometimes, though less likely. If untreated, an episode might last weeks or months. Sometimes it converts back to normal rhythm on its own, or it can degenerate into atrial fibrillation, sometimes quite quickly.
And managing underlying causes helps the outlook.
Definitely. Treating the root cause, if possible, improves the prognosis.
Finally, what if it isn't managed well? What are the potential complications?
Well, number one is thromboembolism, TIA, or stroke. Less common than AF, but still a major risk.
Right.
Heart failure is another big one. The rapid rate can strain the heart, impair pumping, lower blood pressure, even cause ischemia.
And long term?
Long term, that fast rate can lead to tachycardia-induced cardiomyopathy. The heart muscle weakens just from being overworked.
That sounds serious.
It can be. Ventricular arrhythmias are rare, but possible. And then there's the impact on quality of life, the palpitations, fatigue. It's also linked to increased overall mortality rates.
And it can turn into AF.
Yes, persistent untreated flutter can sometimes progress to chronic atrial fibrillation over time. So plenty of reasons to manage it effectively.
Absolutely. Okay, let's try a quick summary then. Atrial flutter. Rapid, regular atrial activity. Key ECG sign. Sawtooth pattern.
Often linked to underlying heart disease and increasing age.
Management focuses on controlling the rate, controlling the rhythm, often with ablation for long-term success, and crucially, managing stroke risk with anticoagulation based on CHA₂DS₂-VASc score.
That sums it up nicely. Understanding those core points gives you a really solid handle on atrial flutter.
Fantastic. For everyone listening, if you want more high-yield revision material like this to really nail your exams, definitely head over to PASMSRA.com and free MSRA.com.
Great resources there.
Thanks for joining us for this deep dive into atrial flutter.